For those of you that have not met me yet, I'm Dr. Sara Mulholland, Vice President of Expansion here at Full Spectrum. And tonight we're going to be talking about trauma-informed care and its application in ABA. For those who attended the Journal Club a couple weeks ago, this is building off that information. Our sign-in code is 9512. Make sure to jot that down if this is for those who are getting CEUs, so our analysts primarily. Task list and ethics code items that we'll be addressing. So first is the BCBA-BCABA task list, E3, responsibility and practice, E4, responsibility to clients and stakeholders, H3, recommend intervention goals and strategies based on such factors as client preferences, supporting environments, risk, constraints, and social validity. H9, collaborate with others who support and/or provide services to the clients. For the RBT task list, we're looking at B2, which is assist with individualized assessment procedures. C3, use contingencies of reinforcement. C10, use generalization and maintenance procedures. F5, maintain client dignity. From the ethics code, 1.07, cultural responsiveness and diversity, 2.01, providing effective treatment, and 2.15, minimizing risk of behavior change intervention. So first, let's review. What is trauma-informed care, abbreviated TIC? Before understanding trauma-informed care, we need to understand the term trauma. The term has had many definitions over time and often relates to perception of events. Many tend to believe the event has to be life-threatening, such as a major car accident, natural disaster, or near-death experience to be considered trauma. However, in reality, trauma can be any event or a series of events that cause long-term adverse effects on the person in social, emotional, physical, mental, or spiritual areas. And long-term here simply refers to beyond the event. So it could be for several days, months, years, or a lifetime. So that is a very wide defined term. So trauma-informed care does not mean that we are discussing the trauma itself. We're not processing it because in our role here, we're not counselors, we're not therapists as far as mental health goes. So trauma-informed care simply means we are acknowledging the presence and/or history of the trauma and how it might be affecting the clients or the stakeholders now. And this understanding allows us to be more person-centered and gain better results. So as we discussed, for those who attended the recent Journal Club presentation, trauma-informed care has 4 commitments. There have been multiple approaches to trauma-informed care in literature, but these 4 commitments appear consistently. And those are acknowledging trauma and its potential impact, ensuring trust and safety, promoting choice and shared governance, and emphasizing skill building. The good news is most of this is already built into the work you do in ABA. You already pair with clients and caregivers. The process is all about connection. So that means you're also building trust and safety. The overall goal of ABA is building independence, which means we're promoting and teaching choice making. We involve the caregivers and other team members in treatment, which promotes shared governance. And more than half of the behavior plan is dedicated to building necessary skills to navigate the world and build independence in multiple settings or across multiple persons. The only commitment here that may not be universal in ABA is acknowledging trauma and its potential impact that it has on the clients and families. We can build this awareness into the foundation for ABA, starting with the clinical interview and consistently evaluating any changes in behaviors and responses. We want to avoid quick reactions to behaviors, including verbal behaviors or seemingly irrational responses. Remember, the response or behavior is not about you. It's about the person engaging in the behavior. So let's review how each of these commitments connect to ABA in a little more detail. All right, so trauma-informed care in ABA, looking specifically at acknowledging presence and impact. This means we're building awareness. So in ABA, we look at reinforcers and punishers individualized to each client. Often this means we're looking at immediate or visible stimuli prior to a behavior. However, sometimes the stimuli is not clear, so we're not sure what triggered it. A seemingly neutral stimulus could be a conditioned reinforcer or punisher for that individual client based on a learning history, which may have involved trauma. So over time, those stimuli could become generalized to multiple versions of the stimulus. And remember, an event that triggers a strong emotional response impacts the person who experienced the response with a much higher magnitude than an event that did not trigger an emotional response. Therefore, it is crucial that we are aware of potential trauma history, or at least aware that it is possible that there is a trauma history, so that we can understand potential triggers and reinforcers, and high magnitude or high frequency behaviors, as well as potential inadvertent punishers and of adaptive behaviors. So we have some examples here of conditioned reinforcers or punishers that could become generalized. For example, a raised male voice has been paired with abuse over time for a child. Now they cower when anyone talks loudly. Someone has aversion to hugs due to a restraint history. Now they engage in aggression in response to any physical contact. They have engaged in physical aggression that allowed them to get away from an aversive task or person. So now that individual engages in aggression anytime something gets difficult. They may have an aversion to attention due to a bullying situation or an extremely embarrassing situation. Now they avoid engaging in adaptive behaviors to avoid praise responses from others. They have a history of having fallen down stairs leading to significant injury, and now they avoid stairs to the point that it impacts decisions or movement. On an unrelated note, I may have made a major life decision regarding 2 employment options in Colorado solely based on the fact that one of the institutions did not have stairs. So the next area is ensuring trust and safety, which for us is simply pairing. I say simply, but it's really not a simple process, as you all know. But once again, we see how elements of trauma-informed care are already built into ABA. For example, the primary component of trauma-informed care is ensuring that the clients feel safe throughout services. That's part of the ethical principle of beneficence. Building trust and safety for the clients and families is already built into our process because of pairing. Pairing is that foundation for effective treatment. This is actually true in other helping professions as well. It's just known by other terms, such as building therapeutic rapport. The same thing as pairing, it's just a different term for the same thing in a different discipline. It's important to remember that the caregivers may have a trauma history as well. So we're pairing with the whole family, not just the child, because we want the whole family to feel safe. We also want to work to create an environment that feels safe both physically and emotionally for all. And part of this is reinforcing and conditioning safety signals. Safety signals are stimuli that indicate predictability and or a time without aversive stimuli. So an example could be having a free play area. So an area that the child knows when they're there, there's not going to be any demands put on them. They can just play. This is truly a reinforcement zone, so to speak. Could also be using a visual schedule so that they know exactly what's coming next and they have that predictability. It could be having a safe space area, somewhere they can go to indicate that they need a break, such as a quiet area. A lot of times we see in schools, they use a quiet area or something similar as a timeout, but it's really nice to see when the teachers or whoever is using it use it instead as a place to just de-escalate, somewhere they can choose to go if they need that. Could also mean that we're using specific areas of the home or a room for specific tasks. So the child knows when I am in this room or in this area, this is what I need to do. In addition to safety signals, we must always identify and respect warning signals and promote adaptive responses to those. Warning signals are basically precursor behaviors that indicate to us that this person is struggling or starting to escalate. So in the chat, I would love for you to give some additional ideas of what might be a warning signal or what might be a safety signal that you could apply in treatment. Going back to looking at things that have become punishers or reinforcers, we have some examples here. Yelling and spanking together can cause trauma for a client for sure. Loud noises, fire alarms, flashing lights, if they've had trauma in the past, such as a house fire or gunshots, or scary, unsafe situations for sure. Yeah, warning signal could be someone starting to pace back and forth. Thank you. Some additional ways to make sure that we are ensuring trust and building safety include allowing modifications based on the child's responses. So when we see those warning signals, we know what modifications we need to make to help that child feel safe. So this might be reducing demands, it might be offering breaks, offering help, it might even be just changing location, going to a different room because something in this room is starting to upset them. Or maybe they just need to walk a little bit, get some movement. We have some other ideas here, closing eyes, fidgeting, red face, tapping feet. Yeah, those are all great warning signals for sure. Thank you very much. We also want to avoid physical management unless there is truly no other option for safety at that moment. It's important to note that the use of physical management can actually escalate the safety risks in certain cases. So crisis de-escalation sometimes might involve reinforcement. We might mildly reinforce a behavior that we didn't want to prevent that crisis escalation, and that is okay. Because if we minimize the escalation and still show them that they don't have to escalate that far. So we're actually teaching them new behaviors. We may have inadvertently reinforced something, but at the same time, we just taught them that when they start down this road of escalation, it doesn't have to go all the way to crisis. Remember that safety is always number one. Once everyone is safe, then we can reset if we need to do so. Some other examples we got here of warning signals: stuttering, change in tone of voice, lack of eye contact. That was previously there. And that's a good note there. So noting that it's a change for that person. Head banging, head in their hands, tears, shutting down. Yes, those are all great signs to let you know there's something going on and they're not feeling safe right now. So the next component we're going to look at is promoting choice, which goes along with independence. Once again, trauma-informed care is already there in our ABA framework as it is. In ABA, our goal is to promote independence. We often say we're trying to work ourselves out of a job. This means that we're empowering the child and the family, the caregivers, to engage in choice and self-management. Remember, this is important for the caregivers also. Ask for their input and their preferences rather than dictating all the time. Make sure that this is a shared goal, a shared process, and therefore it's now part of shared governance. So teaching choice making, as I said before, is already a common goal. So with trauma-informed care, we're going to make sure that those choice opportunities allow the individual to find alternative ways to respond to those trauma triggers and still meet their needs. That's very important. The needs are still going to be there. They need to be able to cope with that. So we need to help them learn different ways to do that. Opportunities for this are definitely going to come at more unexpected moments. You can't really plan for them that well because we don't want to purposely trigger trauma. That's unethical. But things are going to happen that trigger trauma responses. So we want to adapt during that time to help them learn how they can make choices and be more independent to react to that in a different way. So make sure that you are ready to capitalize on those choice-making opportunities in all areas of care. And remember, the choices don't have to be a yes or a no. It could be something like scheduling choices. Do you want to do this activity first or this one? It could be how we work on a goal, looking at their learning styles, letting them choose. It could be when to work. We do this a lot already. Do you want to break for 5 minutes or 6 minutes? So they're making a choice. Promoting choice can also identify novel reinforcers that maybe we didn't know about for that person. Could also help us identify new interventions that maybe we hadn't thought about based on the choices that they've made. Okay, we have a question in the chat. Thank you. What are some considerations of possible trauma-related private events impacting a client's behavior? So we are actually going to talk about some of those here in a few minutes. That is a great question, because a lot of times it's those neutral stimuli are triggering something now because of private events that we're not seeing. So definitely we are going to be talking about that. Thank you, Michelle. So emphasizing skill building. We work on building skills and generalization already. Every behavior plan incorporates skill building in it. So once again, foundations are already in ABA for trauma-informed care. We just have to tweak it in a trauma-informed way. Trauma-informed care approaches build skills to react to trauma triggers, as well as skills that work for the individual's learning patterns. So make sure that you are teaching functionally equivalent replacements. Again, like I said before, the needs are still going to be there. So whether it's a need to feel safe or a need to be able to opt out of whatever this is that's triggering them, we have to be teaching new skills that still meet the same need. Otherwise, it's not going to work. I often give the example of, so I'm a chocoholic, love my chocolate, and if you tell me that I can't eat chocolate anymore, but you don't give me a replacement that still satisfies my sweet tooth, I'm still going to eat that chocolate, right? So make sure that it is functionally equivalent. Skill building in general is empowering for all involved. So it really empowers the child, it empowers the family, it builds confidence and independence, especially when we're able to teach them to generalize these skills to multiple settings, situations, or persons. In general, when we're teaching new skills in a trauma-informed way, a DRA is going to be the best approach. So that aligns best with trauma-informed care. So we're teaching alternative responses, specific alternative responses to those trauma-related triggers. That we're going to teach self-regulation skills, also known as coping skills, but we know we can't use that terminology in behavior plans because insurance doesn't like it. Same thing, coping skills or self-regulation skills. And again, we're making sure that whatever that new behavior is that we're teaching is functionally equivalent. And remember, this isn't just for the child that you're working with. This is also for the caregivers. Looking at some things we have in the chat here. Teacher works on de-escalating the client, but only escalating for sure. And I'm glad I'm not the only chocoholic out there. And that does happen when the teacher's trying to de-escalate, but it's escalating, then there is something being triggered there for sure. And that's an example of being mindful of how the child is responding. And we have to be willing to make modifications in response to that. Someone said allowing them to choose and have control over a small part of the situation can help them feel like they have control in an overwhelming trauma flashback where they feel like they have absolutely no control. That is for sure, for sure. So now we're going to talk about some of the signs of when trauma-informed care is needed so that we can recognize that. So there are a lot of behaviors and responses that can indicate that they are engaging in some kind of trauma response. So remember, number one, all behavior is communication. Sudden changes in behavior are just loud communication. So make sure that you are taking time to look at what is being communicated because they might be telling you that trauma exists and a trauma-informed care approach is needed. So some examples of behaviors that may indicate to you that there's a trauma-informed care need. So these examples first, I want to make very clear, do not confirm a trauma history. It is very possible there are other factors at play. However, act as though a trauma history is present, as that gives you a calm and supportive approach, which is going to benefit the person regardless of the cause or the history. So there are many behaviors that we know are common in autism, and it can be easy to write those off as simply autism symptoms, but sometimes there is another cause, such as a trauma history. That's why we want to use an individualized approach when we see these things happen. So some examples we have here are self-depreciating statements. This kind of an example of those private events could be happening too if they don't have confidence in themselves. We have self-injury. Self-injury can also be a trauma response. It could be that they are acting out something that has happened to them before, or it could be that they are experiencing some type of pain or discomfort and they haven't been able to communicate that to someone. So now they're using self-injury to communicate everything. Isolation and increased masking are also signs. I say increased masking because we know some masking does happen, but when it seems to be more so. So they're mimicking others a lot more than they were before, or their communication has changed, or they're just isolating from others. Something has changed. Hygiene avoidance also. All three of those could be products of a history of bullying, abuse, or neglect. Fear responses could be related to abuse or witnessing domestic violence. Sexual behaviors and aggression could be acting out experiences that they have witnessed or been a victim from. Substance abuse could be an attempt to self-medicate or avoid aversive situations. I'd love for you all to put in the chat some other behaviors that may indicate a trauma history to you. Staring into the distance, pulling back during a situation, flinching when touched, a certain way, scripting things that are alarming or unusual, yes. Unusual behaviors from returning from one of the parents' homes after a visit, that's a big one. Let you know that something happened there. Also, I wanted to touch on the fact that persons with autism often don't process events the same way we do. In general, it can be individualized processing, but especially we see this with autism. Someone may not process the trauma as trauma in the moment, and the responses may not indicate that the person experienced this as trauma, but we might see signs of it later. Remember, delayed responses are actually common for persons with autism. For example, my daughters lost their great-grandmother a few years ago. Their great-grandmother, along with one of their great-aunts, visit every single year without fail. They always come and visit for a week or two over the summer or spring. It appeared after the loss that my autistic daughter was unfazed, even seen laughing and playing, and even had to be taken to another room by me during the funeral because her behavior was disruptive, while my other daughter was heartbroken. However, to this day, a few years later, my autistic daughter will occasionally say, "Great-grandma died, still have Aunt Phil." And she says it that way every single time. The loss has affected her, but she processed it differently. She notices the loss, and she assures herself that everything is okay because Aunt Phil is still there. And I tell you this as an example of why we should not write off a child's experience, assuming they're okay, just because they're not responding as expected. Just want to check the chat here. Removing oneself from a situation, behaviors that haven't occurred in more than a year that suddenly come back, yes. Not wanting to lock a bathroom door or in public places, or having the need to lock all doors. Those are good signs as well. Thank you for sharing. And if you think of any others, feel free to put them in there. I'll be checking the chat periodically. So we already have some tools to assist us in planning for a trauma-informed care approach. We just need to make sure we're using them in a trauma-informed way. So our assessment format involves the clinical interview. So the clinical interview allows us to gain information about current status as well as historical information. We can learn what has and has not worked for that child, common triggers for the behaviors, goals for the child and family, and things to avoid and things to try. When we do this well, the clinical interview is a wealth of information for us. Then we also have the direct observation, which is more than just observing behaviors. You can also note what the child tends to avoid, what they tend to approach, any potential trauma-related responses to stimuli that are just naturally in their environment, identify any approaches that might benefit the client based on observing what they gravitate towards and away from. This also applies to when we're doing the skills assessments. Don't get so focused in the skill-based results that you miss additional information available based on the child's behaviors and actions during that assessment. It is also important to observe the caregiver responses. Are they repeating statements regarding their history or perceptions often? Are they excusing behaviors due to past events? Are they hyper-focused on behaviors that appear minor? This is all information that can assist you in creating an effective, individualized plan from a trauma-informed approach. Some additional tools that you may or may not be using on a regular basis, so I just want to make sure we touch on those. We have the ACEs and the SNAP assessment. We're going to talk about each of those individually here in a moment. But the ACEs is the Adverse Childhood Experiences Scale. And that and the SNAP assessment can give you a lot of information to individualize that approach to treatment. Behavioral questionnaires that you use for identifying behavior function can also give information about potential trauma responses, particularly when a behavior appears to have all the functions, yet does not truly appear to be automatic in function. This could signal that it's a behavior that has been generalized by the child over time, which might be a trauma response. For example, a child who's not been able to communicate their needs for so long, and then they engage in a high magnitude behavior, maybe self-injury, that got everyone's attention, created a major reaction, so now they use it for all communication because they haven't figured out another way to communicate. You want to look at both direct and indirect feedback that you get during your assessment. The direct feedback is what you clearly observe in reaction to the actions. That's your ABC data. It's really clear, laid out there for you. Indirect is what is not said or communicated, but becomes clear over time. This could involve some of those private events that you end up kind of putting the pieces of the puzzle together later. So maybe it was some of those repeated statements by the caregiver that later on you realize, there's a confidence issue here. Or you realize, you know what, maybe they've been bullied, because of their parenting approaches or something to that effect. That's when you know that there's something else at play. So this is the ACEs questionnaire. So you also hear it just called ACE. So both are correct. So the last S just stands for scale. So you'll see it's a simple yes/no format. It looks at 10 possible causes of trauma. I want to be clear, this is not an exhaustive list of potential traumas. It's just 10 major events that research has shown affect children's experiences into adulthood. So the ACEs allows us to identify if these potential trauma experiences have happened and therefore may be affecting the child at any given time. And obviously, this is not something you're going to be able to ask the child unless they're very high functioning as far as their communication goes. But you're going to be getting a lot of this information in your clinical interview. You can work it into some of the questions. So questions like if the parents have ever been separated or divorced, has there ever been domestic violence in the home? Any history of mental illness in the home? Those are things that can be worked into the clinical interview. And this is actually freely available, this document. So if anyone does want it, you just let me know. I can email it to you. It's not a copyright thing. It's out there on the internet for anybody to find. I want to be very clear in this. It's not the score that matters when you're doing a trauma-informed care plan. This is just simply identifying potential trauma history. There are some disciplines that will use a score in this. We're not doing that. We're just looking at potential history. So we have a couple of comments here. It's also important to watch child reactions to the parent's reactions. That is so true. Do they look at the parent before answering you? Is the parent speaking for them? Even if they're able to respond appropriately, those are great. When parents are observing the client in crisis behavior, do they immediately feel the need to defend themselves? And that definitely tells you that there's something else going on for sure. So the SNAP assessment. SNAP assessment is a tool to identify the best approaches specific for the client and family. Some insurances are actually starting to require this assessment in documents as well. We're seeing this in South Carolina a lot lately, which actually shows the beginning of a shift to a more trauma-informed care approach, whether they realize it or not. So SNAP is an acronym for strengths, needs, abilities, and preferences. So when we're looking at the strengths, we're looking at the strengths of the client. What are things that they're really good at that really seem to help them in their functioning or just talents that they have? Strengths of the caregivers. What about the family as a whole? We want to find them no matter how small. I don't know how many of you here watch Good Doctor. It's a great show if you haven't. But they really talked about this in a recent episode. So the main character was having trouble giving feedback to a student doctor who also had autism. And he was told to give it in a feedback sandwich. So that is something positive, then something you want to change, and then something positive again. And he said that he was having trouble finding the positives. And he was told to, quote, find the bread, as far as the bread of the sandwich. And I really liked the way it was said. And when he got frustrated with the student at one point, he said he was running out of bread and left the room. If nothing else, watch that episode. It was great. It's one of the most recent ones. But that is finding strengths. For needs, we're looking at what are those primary needs related to treatment. What is the original reason that they wanted ABA to work on? We want to make sure we're prioritizing the needs. Safety first. Then what is interfering with their goals, their ability to be independent? And also, what are the caregivers looking for? Because again, this is a collaborative approach. Make sure that we're looking at what the needs are related to the family unit and caregiver connections as well. Sometimes we miss that. So we may be so focused on the individual client needs that we forget to look at how are they interacting with the caregivers and what's going on with the connection there. I worked with a young girl that one of the biggest needs of the family was the mom just wanted her daughter to be able to communicate with her dad. And there were deficits on both sides. So working with the two of them together was very important. Abilities, this is different than strengths. So abilities is more the skills that are already in the repertoire. What do they already know? What's our foundation? We're also looking at any unique interests that lead us to find more knowledge and skills that we may not have recognized at first. We're also looking at what the family and caregivers can and cannot do with the skills they have now. Caregiver training is so important. We don't want to tell them to do an intervention when they don't have the prerequisite skills for it either. And then preferences. We're doing preference assessments. That's already part of what we're doing. Looking at what the preferred reinforcers are, what interventions are going to work best. We also want to look at preferences of the family and the caregivers. We also want to look at scheduling as part of the preferences. Make sure that we're doing it at a time for the sessions that are truly beneficial for everyone involved and convenient. So now we're going to go into the actual framework of using trauma-informed care in ABA. So using those 4 commitments, as we've talked about this whole time, starting with acknowledging trauma and its potential impact. So just as a reminder, every component of the trauma-informed care framework in ABA begins with a clinical interview, and it continues the entire time that we're doing treatment. So during the clinical interview, we already ask about history of moves, school changes, family changes, other events that may have affected the child. In this, we can incorporate components of the ACEs questions. We can note any significant events, even if the parent doesn't see an impact on the child at that time. We can ask about any known aversions or fears during this clinical interview as well. Throughout treatment, we want to be observant and notice changes in behaviors or patterns. We have to be willing to make adjustments as needed if potential trauma responses are observed. That is one thing as far as the negative views of ABA historically. Part of that is rigidity. Feeling like in ABA we're very rigid. It has to be kind of a my way or the highway kind of thing, and we don't want to do that. We want to be able to make those adjustments as needed. We want to validate and use empathy for all involved when they're struggling. Remember, that is not sympathy. We're not feeling sorry for someone and excusing poor behavior. We're understanding and meeting them where they're at so that we can begin shaping change. When I worked in the prison setting, I would tell people that, I will understand where you're coming from when one of the offenders was trying to defend their behavior. I would say, you know what, I understand why you thought that was okay. However, it's not, what are we going to do differently? That is empathy, being able to get it where they're at and then explaining we got to do something different or shaping new change. We have to make sure that we're not only allowing feedback from clients and caregivers, but we're inviting feedback regularly. So we're asking how they feel about certain interventions. We're getting their point of view on priorities and abilities. Anytime that I'm working with a child in a home and I'm about to do something different, if the parent is there, I will ask them, I will say, hey, I want to try this. How do you feel about it? Because remember, some of these caregivers may have trauma history that has taught them to be seen and not heard. They may not engage without invitation. And always be willing to make adjustments in the best interests of the client and family. We have a comment here, make sure there's a connection between the school and the family, for sure. This ensures that they're not only receiving resources that we can offer them, but the school and county as well. If in school as the RBT or analyst, having a good relationship with the behavior specialists and counselors, yes, to offer support. It is truly a team effort, and we need to be involved as a team as much as possible, 100%. And that's why I say family and caregivers, because when we're working with the school, they're caregivers too. So next we look at the component of ensuring safety and building trust. So we want to build on the acknowledgement steps. So we've already acknowledged the trauma, that it may be there and that we need to be aware of that. So now we are ensuring safety and building trust. That means we're pairing, which is an initial stage and an ongoing process. We're always pairing. Sometimes we have to back it up and pair a little more for a while, and that's okay. I worked with an RBT that needed to do that because we had a client who was making lots of progress. He had a lot of aggression, and he'd been making a lot of progress. And then some things happened during a home session where a caregiver got involved, let's say prematurely, and basically reinforced some very negative behavior. And for the next week or so, the client was very aggressive towards the RBT. And I had the RBT back it up and just work on pairing with him again as if it was brand new for about a week or so. And then they started working in those goals a little more, and it was very effective. We have to be willing to do that. Pairing's not a one-time thing. So make sure that we're able to work on that again if we notice that some type of trust or safety has been lost. And that's okay when we have to do that. It doesn't mean we did anything wrong. It just means something changed. So sometimes we may need to back off some of our expectations or adjust an intervention to a method that maybe we don't think is as effective, but that's okay too. What matters is what works for the client and family, while of course still maintaining ABA integrity. There are multiple ways to intervene on a behavior or build skills in ABA, so use what's most effective for that child at that time. It may not be your favorite intervention, but if it works for that child and the caregivers, that's what you use. Having safe zones or safe signals are simply ways to let that client know that they can communicate that they need a break, alert them that there are going to be no expectations for a certain amount of time. That could be using a timer for breaks, letting them know, hey, I've got 5 minutes that, you know what, I don't have to deal with anyone telling me to do anything. Signaling clear expectations and making sure that aversive stimuli are not present as much as possible. We all need these signals and breaks sometimes. The clients you're working with are no different. They may just need them a little more clear. Make sure that we also let the client lead whenever possible. Assess when they're ready to proceed when they need breaks. If we have a session that we just need to back off and do the really easy stuff that we know that the client knows already, that's okay. All right, we have sharing here. We also risk creating trauma for our clients if we push too much or don't acknowledge the trauma. That is so true. And that's why it's okay to back off. We have another comment here, going through this right now with a client in a school setting, a similar situation. Suggested to the teacher that we should go back to where we connect with the client more. Couldn't agree more. Pairing can occur throughout the history of sessions. Always good to reestablish. Doesn't just occur at the beginning. Thank you. I'm glad that you all are seeing that too. So the third part here is promoting choice and shared governance. So that SNAP assessment is a great way to identify the client's current repertoire and what they tend to prefer so that we can give them available choices that actually make sense and something that they would want to choose. That way we can allow choice and shared governance when we work with the caregivers as well as the client. We use a schedule that works for them. We prioritize those skills and interventions and set goals based on the feedback that we got. As treatment proceeds, assent is important in every session. So this is the client agreeing to participate and the caregiver allowing therapy and or participating in it. This means that we do allow the client to, quote, opt out of an activity rather than forcing it. When we see the client opting out repeatedly, this could be refusal, this could be saying no, this could be just not engaging, then we need to evaluate the activity and identify what changes are needed. It might mean that we offer a different activity or different choices to achieve the same goal. It might mean that we work on some prerequisite skills that we're missing that we didn't notice before, or that we do some preferred tasks and work back up to that targeted goal in a behavior momentum approach. It might mean that we reduce the demands for a little bit, even if that inadvertently reinforces a maladaptive behavior, because we're also then working on ways that they can ask for the demands to be reduced. Remember the big picture. Safety is always number one. If reducing a demand or giving access to a preferred item deters an extremely unsafe behavior, that is okay. We have taught that child they do not have to fully escalate in order to communicate. And we can reset expectations and practice better ways of handling the situation once everyone is calm. That doesn't mean that we are, quote, giving in to the behaviors consistently. It might mean that we give comparable alternatives in the moment to de-escalate and still work for whatever that primary reinforcer was. Structure this in a way that benefits everyone involved. And then finally, skill building. Skill building is a foundation of ABA. It's already there. We're identifying replacement skills, and this is at least half of your behavior support plan. So that SNAP assessment informs us of what the client can do already, what is reinforcing, and what some of those primary needs are. The overall clinical interview highlights the biggest deficits in the views of the caregivers, and the needs are prioritized based on this information, along with the observations and results of our skill assessments. As treatment continues, we are consistently looking at prerequisite skills that are needed for new skills, and we're revising expectations to allow teaching those prerequisite skills or adjusting our approach based on the client feedback that we are seeing. We're ensuring that we have trauma-informed knowledge when deciding the direction of the prompt hierarchy that we're using. So knowing there may be some prompt types that we're going to avoid based on the needs of that particular client. Maybe physical prompting is not something that is going to help that client at all. It's actually going to trigger them, so we're not going to use it. Even verbal prompting, the way we verbally prompt, may need to be adjusted. And finally, we're avoiding physical intervention as much as possible. There are some states actually that do not even allow physical intervention in the home or school setting at all. So it's okay to ask a caregiver to be involved if needed. They know their child best, and that's probably going to create more safety for that child, hopefully. And by this point, you probably already know that. Assent-based practice, yep, it's very, very similar. A lot of carryover with that. So for the last little bit here, we're going to do some case study examples. And these are real-life examples and how trauma-informed care has been applied. So the first one here, and I'm going to go over these examples, and I want you to be thinking about ways that we could use trauma-informed care and put some of those ideas in the chat. And then I will talk about what actually happened with each of these. So the first one, severe self-injury. So this was a teenager who was nonverbal, lacked many basic skills, tended to engage in severe self-injury, had caused himself some significant injury over time. Had a history of very restrictive interventions being used, even had to wear padding on most of his body and a helmet for a long period of time before entering ABA. The teacher in the class actually forbids hands-on interventions for that particular person in the classroom. Instead, she tends to turn down the lights and give space. But yet when crisis intervention staff are called for this particular individual, they would use physical management, which consistently resulted in medical intervention being needed. So I'd like you to put in the chat, how is trauma-informed care already being used for this client, and who is using it? The next one is increasing physical aggression. This was an adult who is verbal but doesn't really talk much, just doesn't really interact. He doesn't interact with peers or staff, often seen pacing through the home. It was in a group home. Has a history of walking into rooms and just hitting somebody without any clear antecedents. This would escalate to severe repeated aggression, sometimes followed by elopement down streets or severe property destruction, such as bashing in the windows of staff cars. This led to staff avoiding eye contact with him or any interaction when he would enter the room, and the frequency of this behavior continued to increase. What are some ideas that you could apply for this client? So for the first one, the teacher, by lowering lights and setting boundaries and not touching him at all, 100%. She is using a trauma-informed care approach. And I will tell you, as the analyst, I was so uncomfortable with that at first because I am watching this person literally beat himself up, and she is telling me not to touch him. And we had to call for crisis intervention because we can't let him hurt himself. But then I saw the crisis intervention come, they put him in a hold, and ambulance got called. So I'll tell you the results of that one while you guys think about the second one. We ended up focusing on communication goals. We did avoid physical intervention. We made sure that we had a blanket that he preferred handy so that we could give that to him to hold in his hands. Sometimes it helped him to hold someone else's hand, but you had to be careful because he was very strong and he could actually hurt your fingers without realizing it. You had to be careful how you did that. So we would just turn the lights down as the teacher did, give him some space, give him that blanket, turn on some soft music, and then we really built in basic communication using a modified PECS with him, and the frequency of self-injury decreased very rapidly. When entering the room, stating why they're there or who they're there for, have positive interactions with the client and show that they're not afraid, which was very hard because I will tell you the staff were deathly afraid of this man because he had put some in the hospital before. I mean, it was a valid fear. So as far as what happened with him, so I was the analyst for this one as well. I was involved in all of these cases at some point. So for this one, I trained staff to acknowledge him when he came into the room and offer interaction, knowing that he would decline. Realized that this particular individual wanted to be noticed and acknowledged. He did have a history of being very neglected, even though he didn't really want to socialize. So basically, he wanted to be invited to the table so that he could tell you no. And he would say it nicely. We'd say, hey, you want to come play cards? And he'd be like, nah. And he'd walk away, but he wouldn't hit anybody. Over time, he did begin interacting in simple activities with us, and his aggression frequency went way down to the point that people were not as afraid of him anymore. Got two more examples. So this one is for these examples are specific to caregivers. So the first one was when we're initiating services. So, and I was not the analyst for either of these, but I was involved in some of these cases as well. So prior to service starting, there were many conversations between the mother and I was part of intake for this one, so and myself as well as intake, reporting that the child was having to be picked up from school due to the behaviors. They were desperate for services, saying, somebody please help my child. They had to wait a long time for the case to get opened and then for an RBT to be available. Finally got an RBT available, case was opened, everything was good, we were approved for a good amount of hours, and communication from the parents to schedule was suddenly very lacking. They eventually were able to schedule that initial session, and in less than 30 minutes before the session was to start, the parent suddenly canceled. What do you think happened? And what might we do about that? While you're thinking about that one, here's the other one. So sudden termination of services. Parent would often talk to providers about her own experiences, seemed paired very well with both the analyst and the RBT. During the assessment, so I did this one's assessment, and the mom frequently would answer questions about the child and say, oh, I look like a bad mom. And I would constantly, try to validate her and tell her, no, this is autism. You're not a bad mom. This is an experience. This is why we're here. The family moved multiple times after services started, which was a lot of interruptions in services. Sometimes the parent made some prejudicial comments in front of the RBT. Then we had a session that had to end suddenly due to possible lice being found. The parent called me the next day and said she wanted to end services. What do you think happened there, and what might be some solutions? So the initiating services one. The analyst confirmed the next session with the caregiver, multiple communication methods to make sure there was no miscommunication whatsoever. When the analyst and RBT got to the home, they learned that the mother was worried about being judged for the state of the home, which they said was not bad. But the mother confessed there had been a history of CPS involvement based on the opinions of others, and she was scared that was going to happen again. So she had a lot of fear herself. There were definitely some private events going on there as far as her own self-confidence in how she was caring for her family. Our staff assured her that they're there to help and not judge, and things have been going smoothly ever since, and they all seem to be getting along great. As far as the termination of services, so I understood from doing the assessment that mom had a lot of insecurity and was constantly worried about being judged, likely due to some trauma in her history. And there was an addition of recent chaos in the family. So she had shared with me some of the reasons for the moves. There was a lot going on there, and a lot of insecurities, a lot of fear, and just feeling chaotic in general and worried about the perceptions of others. So I listened to her concerns, realized that the base of this was likely her fear of being judged. I also learned that some of the inappropriate comments she made around the RBT were definitely things that were very prejudicial. So she likely did not want to face that RBT again. And I will tell you, the counselor side of me wants to say, we need to get you two together to talk about this, but that is not my role in ABA. So I didn't do that. I recognize what my role in this case is not to force facing the issue, but to instead find a trauma-informed way of ensuring the client and family are still able to get the services that they need and clearly still want. So I offered to change RBTs for a fresh start. She accepted this, and it's actually worked out really well for both RBTs involved. It does happen a lot. Yeah, the caregiver's insecurities are a factor many times. Someone says she seems like she may have low self-esteem. This is about the mom and the termination. Doing things that she knows are not right or trying to cover for it. Leaving before being left. Yeah, for sure. Any questions or comments? And there's the code for your certificate also for those who are getting CEUs. Thank you. I'm glad you found it helpful.
The sign-out code for this presentation is 2159.